it was a rough end to the summer and early September, because I was just experiencing this intense anxiety, which again was not because of the state of the world or the elections or anything else, it was because my system was so just going haywire that I had every symptom of anxiety. It was all autonomic. And of course, then I react to that being like, how do I leave this? And I don't have control.
I thought you and Gene Massey had a really good conversation about that on your YouTube channel, and that it comes a self-fulfilling, snowballing kind of thing.
Yeah.
You know, but that was I listened to, I don't treat scoliosis a ton, but I have one right now. And so I listened to Lisa and Gene, and I haven't got to Susan yet, but those are really good conversations. I think scoliosis is one of those things that I think PRI Nation just really, we've heard the thing where it's the left AIC, right BC, until you're like, but the spine's going left. You know, how is that the same? You know?
Same. It's always thrown me off. And so I'm always hesitant to do anything scoliosis patients, because I just don't know enough. And so that's why I did part of that, at least, was, hey, I get to learn as I'm interviewing them, but people need to be more aware of the fact also that one of them, I can't remember if that was the newest or the earliest, the latest interview, when we mentioned, she mentioned that like everyone's scoliosis is a little bit different. So you can't use just a cookie cutter approach. Yeah. And that's the thing with PRI itself. And by the way, I'm already recording, so I'm just gonna, I'll edit out anything that can't be heard. But I think some of this conversation is actually really good. So
yeah, for sure.
I'm just gonna go with it a little bit.
Yeah.
This is one of the things. So I said, so what you're telling me is someone writing to somebody else say, hey, what did you do for your scoliosis, is not a good way of doing this. And
agreed.
And we all want this reductionist approach. And that's what you see on YouTube. Do this one exercise to get rid of back pain. Yeah. It's never going to work.
Right.
It appeals to the masses because it appeals to your desire for one exercise to fix everything. Yeah. But even with PRI, like someone was interviewing me once a couple months ago for a podcast, and he said, what do you think about the argument that PRI is too reductionist? I was like, reductionist? I had never heard that.
Yeah, me neither.
And then I realized, because I'm so deep into it, we just take for granted that everyone needs the same things. And the difficulty is what's stopping them from getting those things. That's the way I look at it. Like, where's the inhibition occurring in their life that's preventing them from getting into that left side and alternating appropriately? Yeah. So, but it's not reductionist.
Yeah, right. And that's exactly right. That's the common flaw, I guess, that people kind of stumble into is, you'll say that everybody needs the left leg, so you're just going to give them a left leg exercise. Oh no, agreed. However, how that brain can process and do the math to then use said left leg, maybe that's a sitting or a side lying or standing or a hook lying or a 90-90 or an all four position, to have their brain do the math and realize, oh, I own a left side. Mm. So I think you're exactly right. They might need a left side, but how we can get their brain to access that.
Yes.
That's why there's 85 different ways to do it, because we're talking about neurology.
Right. And that's a huge, I guess because I wasn't trained traditionally in any way, like in terms of physical therapy, and you were, and I think, didn't you go to like
osteopathic school? Yeah.
Yeah. So explain that, because, Ron always says that a lot of these concepts that we use in PRI came from osteopathy and cranial sacral. But can you just explain the difference, and that they stopped short of seeing it as an overall pattern?
Right.
So can you explain what that is, and what you would have in common between PRI and osteopathic medicine, and then what the differences are in your view?
Sure. So kind of in a broad spectrum, osteopathic medicine is a way of looking at how it's a very mechanical, it's a very mechanical is probably the best way to say it, of how joints fit together, and the relationship between how a hip joint can influence a lumbar spine, can influence a thoracic spine, can influence an occiput. So it's a very interrelated, interdependent methodology of looking at the system from top to bottom. So if you're, the way that we got taught in PT school is, you might be looking at the lumbar spine, but you have to take into account that there is a pelvis there, there's a sacrum there, and there's a thoracic spine on top of it. So they fancy themselves as and not that they're wrong, as a very holistic approach, because they know, because of this linkage from OA down to the calcaneus, that you can't really look at the exact source of their pain. You have to look at what other things can influence that particular region. So you might have to do the things I learned in school were a lot of traditional osteopathic treatments like muscle energy technique and positional release, and we learned Fryette's laws in PT school. So there was a lot of joint mechanics related to how the OA works all the way down to the sacrum. We spent a lot of time on cranium, neck, thorax, not really the rib cage, lumbar spine, sacrum, and pelvic mechanics. That was like 3 or 4 months worth of work, and then all the manual osteopathic treatments that go along with those, with the exception of what's called a high velocity, well, basically a thrust, like a grade 5.
Yeah.
We didn't learn those, but my roommate in PT school was a doctor of osteopathy, a DO student. So, and I went to college with him. So we did kind of lab on each other. And so we got to kind of practice on some things. So that was very helpful as well, because he was getting those HVLA, high velocity, low amplitude thrusts. We were learning the same mechanics. It's just in PT school, we went down more rabbit holes as far as mechanics went than the DOs did. But like our textbook learning it was the same, the DO and the PT, so that's where PRI then comes in, is PRI then has that same, very interrelated, interdependent system between how the head, the neck, the mandible, the cervical, the thorax, how all those things are kind of fit together. And that has a very osteopathic feel to it. But a lot of times with the osteopathic treatment, they'll still go after the one specific spot. Okay, I'm going to try to get your SC joint to roll superiorly more. Right. Where PR is like, that's all well and good, but that's not going to matter until you have the rib cage and pelvis underneath it doing its job so the scapula can get out of the way.
Right.
So PRI takes a more broader holistic approach, as opposed to osteopathic is still holistic, but in my mind it's a little more of a narrow holistic approach, whereas PRI is a much more global holistic approach.
Yeah, and in that, I just had a consultation yesterday with somebody in California who, of course, everyone's telling her she's crazy, but she's not. Right. And because we have similar experiences, and she went to see somebody who, I don't know what this person's background is, but they were doing some kind of either cranial sacral or osteopathic manipulations on them. And they started on the right side of her face. Yeah. And she said that when she left, this is why it was so great, seeing more.
Oh yeah.
And so and I said, that was what that guy did was great, but it's not integrated with the rest of your body.
Exactly. Yeah. And so what PRI in my mind, what PRI does is takes the osteopathic viewpoint of interrelationships, and like in a lot of the mechanics of, cranial mechanics, OAC1, all the way down, a lot of the mechanics that are involved in that axial structure is like straight out of the osteopathic handbook. Yeah. That's because, osteopathic methodology has been around for over 100 years. So in my mind, anytime something's been around for like 130 years, it can't be because it's wrong.
Right. There's a grain, there's some truth to this thing.
Exactly. And I use this example all the time. I don't know a whole lot about Eastern medicine, but it hasn't been around for 3,000 years because it's incorrect.
Correct. Right.
Okay.
There's a track record there.
Exactly. Right. So what PRI then does is then sees this mechanical model, appreciates it, and says, I'm into this. However, in using your patient as an example, yes, let's get some better movement in through here. But then what PRI does is take it to the next step and say, let's integrate this thing you just freed up. Let's integrate that into a system that can use it, appreciate it, and know what to do with it so that this problem doesn't come back again. And that was kind of the hang up in PT school. There's a lot of us who are like, this muscular energy stuff works. It's great. What do we do with it after this? Because what's prevent it from coming back again? And the answer was, oh, then you do some neurological re-education, PNF kind of thing. And we're like, okay, that's cool. Like what exactly? Like what would be the next thing? And so that was kind of the next step that as a student, we really never quite kind of crossed that bridge. And part of it might've been a function of time.
Mhm.
Part of it might've been a function of the teacher realizing, well, I can't, if I give you an exercise today and show this to you, you can do this on everybody, your success rate is going to be about 15%. For the same neurologic conversation we were having earlier. You know, you can't just use one exercise and try to clean up the whole system for everybody, you know. And that might have been part of the reason as well. But that was the thing that was really kind of frustrating was, okay, even as an early clinician, I would do the muscle energy techniques and be like, okay, my schooling says that you're done, go on your merry way, and it wouldn't stick. And so that was part of my problem.
Not everyone's going to know what muscle energy techniques are. Can you explain two things? Muscle energy techniques, why they may be effective in certain instances, but also PNF, because I don't know a lot of people are going to know what that is.
Okay, so muscle energy technique it's an osteopathic treatment, and it's abbreviated MET, but muscle energy technique is, using palpation, you determine a rotational dysfunction, and lumbar spine or cervical spine is one of the more common places you'll use it. Is you'll do a sagittal flexion extension, and then from there you'll be able to determine a rotational dysfunction that shows up more obviously, usually in flexion. And then what you do is you then put them with palpation, you kind of put them in a position that kind of leads them into that dysfunction. And what you do is they do then an isometric rotation the other way, but you hold them still. So they isometrically try to rotate into you. And because you put them closer to that end range of dysfunction, the muscles that control lumbar rotation can then derotate that lumbar spine.
Got it.
You know, so you're holding the spot that should be moving so that the spot you want to move can move. So it's an isometric thing.
Not to interrupt, but when I used to teach dancing, when I would teach what we call Latin motion in salsa.
Yeah.
You know, the idea of separating snowballs, right?
Yeah, exactly. Yeah.
Separate their thorax from their pelvis, or rib cage from pelvis. So I would literally, and this was before I even knew what PRI was really getting after. Maybe it was before, I just knew they could not separate their pelvis from the rib cage. So I would hold their shoulders. So they couldn't move the shoulders, so they would just have to move the pelvis itself. Otherwise, everything just moved as one. And that's how without that, I don't know whether I would have understand what PRI was trying to get at without my experience in teaching dancing and seeing people who could not separate their body into different snowballs, so to speak.
Yeah, and so that you're having them sit, so that kind of locks the bottom snowball. Mm-hmm. You're kind of you're kind of hugging them with your arms across their body, kind of have the upper snowball. And then you got your fingers in the back, so you kind of palpate their transverse processes. And then you ask them, okay, very gently, can you slightly turn to the left? And you're restricting them. Yeah. So they're trying to turn left, but they can't. And they're sitting, so that locks them in the bottom too. So they get just a little bit of turn. Oh yeah, can you then lean to the left a little bit? Okay, no, lean to the right. And then you can feel that lumbar segment start to derotate. And then when it derotates, you retest them, and then they go forward again. That rotation is now gone. And so that's a successful muscle energy technique.
Got it.
What should happen after that then is that should be followed up with some kind of restorative activity. So then that pelvis and spine and thorax understands then how to rotate one way correctly, but rotate back into the problem they just had safely and be able to get that alternating mechanical system again, as opposed to just let's do this technique and then let's hope that your body figures it out and then you're good.
Right.
So then PNF is proprioceptive neuromuscular facilitation, and that's been around for the two therapists that came up with that. That's got to be, I don't know, I have one of their original textbooks here somewhere. It's from like the 1950s, and it's basically working on the concept that every muscle is triplanar. So what you want to do is work on muscles.
Which is a huge concept.
Absolutely.
Because it's a huge concept for everybody to realize.
Yeah. And so all of these PNF activities, and it could be pelvis, it could be shoulder, it could be hip, it could be occiput, doesn't make any difference. They all have a rotational triplanar diagonal component to them, so that you're using muscles in groups, in teams, in a chain, if you will, to then repattern behavior that's more of a complementary, holistic, triplanar approach in my mind, this is my opinion, in my mind, the downside of PNF is that it's too difficult to regulate. Like
What?
you're like, because you're saying, oh, if they do this diagonal, they have to be using muscles X, Y, and Z. Not if they don't know how to use muscles X, Y, and Z.
Right, right. Not if they're patterned.
Exactly. Now, if they're patterned in a wrong pattern, they're still going to do that motion, but they're still going to do it wrong.
Yeah.
So while it's there's some schools and there's some PT schools that spend a lot of time on PNF. And I think to a certain extent, those students are leaving with a much better appreciation of the value of a concept then of PRI from a chain pattern holistic treatment approach and looking at how do these teams of muscles and groups of muscles work together. So that's PNF, that's muscle energy. And so I had some PNF, but I didn't have a ton, but I had a ton of osteopathic and muscle energy approach. But the thing that for me though was of the most value going into PRI was having a really good understanding of how this interrelationship worked from the cranium all the way down to the floor and being able to put those mechanical pieces together. I didn't have the muscular chain concepts that PRI has. I didn't have that, but at least I could see how this muscle could influence this other part way down here, even though they aren't really close together because of this osteopathic mechanical framework that I had.
So even though you may not have understood how all this occurred, it wasn't implausible to you.
Correct. Yeah, I can make that jump. That wasn't a very difficult bridge for me to cross. Yeah.
So I remember reading a criticism of the myokinematic course. Some physical therapist in New York who seems like a really smart, nice guy. But he wrote a criticism that he couldn't believe that all this dysfunction could occur just because of this left AIC pattern. Now, unfortunately, he clearly wasn't aware that there is the whole rib cage, the cranium, and all these other influences. But I wonder how many people struggle. I didn't have an issue with this integration concept of, oh, hey, by the way, your pelvis issue could be because, you know, your right masseter is, or your right temporalis is too tight. That really didn't, I just was like, wow, this is amazing.
Yeah.
It wasn't hard for me to make that leap. Because you do teach, so everyone should know that Dan is a PRI instructor. He does myokin. You're now doing respiration and everything else.
Impingement stability.
Okay.
Yeah. So doing those three courses. Yeah.
So you must get questions.
Oh yeah.
A lot of people about this.
Yeah.
What is the greatest sticking point for people to see this integration concept? What is it, their formal education, what they've already learned?
For sure. The people that are the hardest, most challenging population to get to cross the bridge from, you know what, if your temporal bone is not doing its job, there's a really good chance that your left leg isn't either, okay? So.
Can you just say that again, please?
Yeah. So if your temporal bone isn't wobbling, isn't doing its job properly.
Because people may not know what the temporal bone, can you point to your right temporal bone?
Temporal bone.
Okay.
If your temporal bone, which is the joint of the TMJ, okay, if that temporal bone isn't, well, let's back up just a second. By the way, your cranium bones move.
Yes, they do.
Okay. I had not husband and wife, but their fiance, man and woman dentist yesterday.
Oh. And
we're talking about, I'm like, listen, we got to get your cranium bones to move. And they're like, pump the brakes. They don't move. I'm like, let's have that conversation for a second.
Yeah.
Okay. So cranium bones move, because if they didn't, any bump on the head, your brain would slosh in itself and you would be dead. Okay. If it didn't. Number two, every time you sneezed, your head would explode.
Yeah.
Okay. Yeah. So your cranium moves absolutely move. So if your temporal bone, which is the joint of the TMJ, think of it as your hip. If that temporal bone isn't moving the way it needs to move every step you take, guaranteed neither is your pelvis.
As slight as that movement may be.
As slight as that movement may be, we're talking about microns of movement, okay? As slight as that wobble is, if that isn't moving in microns or microns of millimeters, neither is your pelvis moving in centimeters.
There you go.
Okay? If that relationship doesn't exist, you can't use your left leg.
Right, and that is like, maybe because if I hadn't felt it.
We've talked about this before. The advantage / disadvantage that Neil has is you feel everything.
Everything.
And that was this other patient I was telling you about yesterday.
Yeah.
Very aware, very sensitive to everything. That's a double-edged sword.
It is. It is.
You know, in some aspects, it is a gift in that you can really hone in on what the actual issue is. On the other end, I'm sure it's kind of like, you know, when Superman gets his powers for the first time and he's bombarded with all this extraneous information. I'm sure it's got to be hard to kind of weed out what's a problem or actually isn't a problem. You know, what do I need to pay attention to? What don't I need to pay attention to?
Right,
you know?
right. So just getting back to like, who's the...
Yeah, I would say a traditionally trained, American trained physical therapist is a challenge because that's not how we're usually taught. And I'm not sure it's really the educational system's problem in that you got to start someplace, right? You have to be able to water it down to a point where you can educate a group of people who are new to this particular genre of profession and at least get them out the door at a level that they're not going to harm anybody. You know, so I think that's part of it is that we get a very siloed, regimented kind of non-interconnected educational base. And so then as people are going and getting into some kind of continuing education courses, I think it's difficult for them to break down those silos and understand that muscle contraction is not a muscular event. It is a neurological event that is based on the brain's interpretation of gravity. Now, they're like, oh, cross fibers and myofilaments. And I'm not saying that not happening, but the reason why that's happening is because of the brain. And if the brain isn't appreciating gravity appropriately, because they're not sensing it the way they need to or whatever the issue is, muscle contraction will be flawed. It'll be mistimed, miscalculated, and with the wrong other teammates in your body. That's compensation. That's an itis. That's dysfunction. I think it's easier to learn that and not unlearn the other than it is to unlearn some previous dogma and then get into this particular mode of thinking.
You have to somehow you have to be able to, it's like I always tell people, I have these two different views. You have this global view, which is standing up, not falling down, gravity, ground, moving. Then, and I would probably say sensory in that. And then you also have this more local level of how that femur and acetabulum work on each other, how that rib cage moves, how that shoulder should move. But you have to be able to zoom in and zoom out and alternate between that more global view of this stuff has to be in order for that more local view to work properly. But even with PRI, you have to figure out a way to teach it, right? So you have to start with these introductory courses where they are segmenting things. Although I'm sure Ron would prefer not to have to do that, but as it evolved, he has to.
He doesn't want to teach it that way. He absolutely does not want to teach it that way, but he's like, I kind of have to.
You have to, yeah.
Oh, if it was up to Ron, this is my opinion. I haven't really talked about it. My impression is if it was up to Ron, we really wouldn't be talking about joint mechanics ever. You know, but it's very, and so I using a similar analogy, I use a trees in the forest kind of analogy, right? So we get taught trees. We got taught needles on trees in PT school, very specific, drill down to the actual joint mechanics and like, how does the navicular and the foot work and what's the pulley in the line? Okay, that's great. You know, the acetabulum and the femur and you're gonna get all those things. That's great, and that's a great place to start. That's the needles in the trees, but you got to pull back, like you were saying, and get a broader scope of how does this system work together from sensory integration to perception to motor, because ultimately the things we're interested in changing from PRI is we're interested in changing the things that you are not consciously aware that you're doing.
Right.
Breathing, chewing and swallowing, and walking.
Right.
And those are the three things that your pons, medulla, cerebellum, basal ganglia, all those automatic nervous centers that take their cue from the motor cortex, don't get me wrong, but all those things become kind of a background, like a computer, stuff running in the background that you just kind of take for granted. And those are the things that we're interested in changing.
Right.
That's the tough part about PRI. So what PRI does is starts with the nitty gritty of here's the joint mechanics, and we just kind of back our way out so you can get this broader scope of how to be able to manage the entire system. It's the backing out part that's the struggle for a lot of people, myself included. I'm going to include myself in that. To get to be backed out enough to be able to see, okay, there's the forest. And for some people, like I said, you and I talked before, you had the advantage of you saw the forest.
Yeah.
You
It was
know?
forced upon me.
Yeah,
It wasn't my choice. It was
No,
just,
you're right. Yeah.
yeah.
Here's the forest. And oh, by the way, your forest is like this, you know? And so
Yeah.
it was, and I think for some aspects, that's been a much, and easier might be too watering it down, but it's been a different learning approach for you because you've experienced it as you've been learning it, as opposed to like a physical therapist who has to kind of unlearn some things in the process. And that's been a difficult hurdle because, so the way I tell people is what you learn in school isn't wrong. It's just incomplete.
Okay.
Because we get taught the tip of the iceberg. And while the tip of the iceberg is a thing and is viable and is an object, there is so much more happening below the water that we don't, and you just don't have enough time in PT school to get taught all that stuff below the water. And so that's where Con Ed comes in. And the other analogy I use is that what a lot of continuing ed courses do is they're on the water in a boat. They've moved away from the iceberg and they're looking through the water like, hey guys, there's stuff below the water here. We should learn this stuff below the water. And then even take a mask and stick their face in the water and be like, wow, that's some cool stuff underneath there. What Ron has done is put on scuba gear and gone to the bottom of the iceberg and looking up from the other end and saying, you guys should really take a look from the other side of the spectrum here and look at what's actually driving this stuff on the surface.
Yeah.
Now, and there's some of us, as we're trying to get closer and closer to the other point of view, that it's just a different way of looking at things.
Yeah. And I think kind of what you were saying, I remember when I first started taking the courses, and probably like the first time I took I&I, which I understood nothing, which the first time I took any of the courses, I really understood almost nothing, which is a normal experience.
Absolutely, for sure.
You know, you get very frustrated, especially the second day on Sunday, like Sunday afternoon, you're just like tearing your hair out and you just want to like go home because you're just overwhelmed. You'll never go away from a PRI course saying, gee, I didn't get my money's worth. I didn't get enough information. That I can guarantee.
Yeah.
And it's just information overload. But I think a lot of times when you're thinking more orthopedically, like muscles and bones, as the primary thing you're learning, you start to learn about I&I and the references and say, oh, there's this other cool part about PRI. And then eventually you make that switch and saying, that's really the whole thing. And everything else will just kind of work out on its own if you have those I&I concepts. Yeah. So maybe I might simplify it a little bit, but without that sensory input being correct and feeling things in the proper position, you know, you may not get your hamstring, you may not get your right glute. If you get those references, those muscles will turn on. If I tell you to feel your left hamstring or your right glute, you're not guaranteed to get those muscles.
Right. And that's the other thing is you can't, to your point, you can't tell somebody, feel your hamstring, because then they're just going to contract their hamstring. Right. Well, an isometric contraction of any muscle is not a usable thing because the joint didn't move. Well, if the joint didn't move, what are we doing here? So that's where I&I, impingement stability, that course is a game changer for most people, because then you start to realize that we are trying to remap in your brain how your body uses itself against gravity by going after the things that you take for granted, but we have to go through the motor cortex to remap those things, which means you have to give you a landmark that your motor cortex can grab onto to know where you are in space. That's the references, so that you can remap and reconfigure the things that you've taken for granted in the first place.
Okay.
And then breathe differently while you're doing it. Can
you restate that in slightly simpler English? Because that's a huge, so we're talking about the impingement and instability course for anybody who has taken seminars, which just, so restate that.
Okay. So when you take the introductory courses in PRI, we talk a lot about mechanics, we talk a lot about muscles, and we don't talk a ton, except in the respiration course, but other than that, we don't talk a ton about neurology and how the neurology influences the musculoskeletal system. In respiration, there's some, but myocane there isn't, and pelvis there isn't much either. Okay. So now you get to impingement and stability. So impingement stability is the concept of impingement is good, instability is good. You need them both. They're not bad words. And B, in order for us to do the things that we are telling you that needs to happen, and that you've taken the first three courses, you understand needs to change, in order to implement those changes from the first 3 courses, we need to remap the cortex of your brain. We need to introduce a different motor planning concept. Now, that's not an easy task, because whatever happens to the motor cortex related to breathing, chewing and swallowing and walking gets eventually funneled into the, we'll call it, unconscious areas of motor. So that's your cerebellum, basal ganglia, reticular formation, medulla oblongata, those kind of brainstem areas. So in order for the brainstem area subconscious part to make a change, it has to go through the cortex first. So we need to make the brain aware of these landmarks.
And that's a huge concept, awareness.
It has to be, exactly, you have to be aware of these landmarks. And these landmarks are first introduced in a more concrete fashion in the impingement instability course of, we need to make sure your brain can recognize the fact that A, you have these landmarks, B, what do they mean, and C, what do you do with them? And that they're asymmetrical one side versus the other, because we're still after the same agenda that you learned in the 3 introductory courses. We're now just going about it much more from a sensorial standpoint, not a musculoskeletal standpoint. Right. And that's where in I people are either on board or they're not.
Yeah.
And so I a lot of times gets to be the dividing line where people are either like, okay, I'm in, or they're like, this is just, I was okay with the other stuff, but this is a little bit too abstract for me. So it's kind of like I ends up being like a weeding out class that people are either going to go into their eyeballs or they're just going to be ankle deep and be okay with it.